Tonight, as we approach Christmas, I know everyone's very busy, and I wanted to say a big thank you to Professor Borody for coming up from Sydney tonight, taking time out of his very busy schedule to come and talk to us. He's a very esteemed gastroenterologist in Australia, very well known. I think Prof Borody started his career at the Mayo Clinic in St Vincent's in Sydney before starting the Centre for Digestive Diseases in 1984. I think your first FMT involvement was in 1988, if that's correct. And around that time you were very involved with developing triple therapy for peptic ulcer disease. You've since gone on and been involved in overseeing around 12,000 fecal microbiota transplants, and recently had a paper published in The Lancet in 2017 and presented at ECHO that same year. So without further ado, I'll get Professor Borody to come up to the microphone and do his talk on FMT and IBD. Thank you.
Sam, the Society, thank you very much for asking me to come over and be controversial. That was the criterion. Well, it's very easy to be controversial. Jake will tell you. So tonight, I hope to be talking mostly about FMT, but we'll finish off at the end because of the recent October 30 presentation of Red Hill Bio, who did 331 patients using the antimicrobacterial therapy, which was shown to be better than standard of care. And we've got a number of patients who then follow on with FMT, so we'll finish off on that. So to start with, let me get this right. You've got to do your own disclosures. You know, I always think that when people do disclosures and they talk about something they do, they should now sit down. That's so true, isn't it? Well, I should sit down now. So I'm involved with a number of these companies, but one that I'm most proud of is Finch Therapeutics. So we're part of Open Biome because we set up, a patient came along and put in $20 million to produce capsules, as we call them, which is, you know, FMT capsules. So we developed those, and the trial's running in the US now for CDI, C. difficile infection. And we had a lot of intellectual property, and Finch, which is Open Biome, they had none, so we did a joint venture about 6-8 months ago. And so we develop odd findings with FMT, and then we start doing small trials, and if it kind of works, then we do big trials. So that's my job with FMT. And what I'd like to do is to review the use in C. difficile and what's new, review the state of the field in FMD and IBD, and what the emerging indications are. And most of you will know that it was first practiced as an oral yellow soup back in 4th century, mentioned in a publication in the 16th century. And the thing that was missed out was putting it in by enema, although I heard recently that it was actually mentioned somewhere else as an enema, because they would have figured out if they did it enough and would have written it up. Transformation was in animals, and Eisenman, I really have great respect for this guy who, in 1957, did 4 cases, wrote it up in 58 in Journal of Surgery. And mind you, that wasn't C. difficile, because that wasn't described till 78. But they had like a 74% death rate when all these new antibiotics came on the scene. And Eisenman was a surgeon, and they were dying from this pseudomembranous colitis thing, you know. And he decided to repopulate the colon, got a couple of nurses, did 2 FMTs, and I can just imagine, and it was going, I'll show you the story, you know, Mrs. Jones, your husband's very ill, he's got pseudomembranous colitis, and the survival's not really high, but we thought we'd just recolonize his flora and give him an enema of someone else's bacteria. And she agreed. He left hospital in 10 days. I mean, that must have been like what we see when you do CDI. They reverse so rapidly, don't they? But it just shows you the power of the microbiome. So we started doing, in 88, 58 to 89 were more cases done, quite a few in Norway and Sweden. And We've done actually up till now about 16,000. We would do 15 a day currently. Other clinics started to administer FMT in the US, and then the FDA got it wrong, which is really good for us, by the way. They rue the day that they prevented FMT being used elsewhere. They were so afraid of stool transmitting infection. And in the odd sort of 75,000 FMTs that have been done around the world, there has been not one documented infection spread. And I've always wondered why. There must have been more. But nobody wrote it up. Or maybe there wasn't any more. Until we figured it out. When you do an FMT, you spread something else. It's called colonization resistance. And when you read deeper into it, if you spread some stool on a culture plate and you want to inoculate it with E. coli, nothing will grow. It kills everything. Stool is a factory of millions of antibiotic-like substances. And that's probably why it kills spores. Is there any antibiotic we know that kills spores? Well, it's in there, but we haven't purified it. So other clinics started doing it. FDA blocked all the users over there from doing other than CDI. Oh, yes, you can do it, but you have to put an application in for an IND, investigation new drug application, and get an IRB approval, which is like an ethics approval. And to get an IND approved, you need to have a trial that's large enough to show a difference, which means you may need 120 patients. Then you need to have the funding, so that closes it. $40 million, how long, you know? You can't do that to science, but they did it. They did it so well. And I know the inside people in the FDA, and they rue the day that they did it, they just don't want to change it. So it's very hard for them to do this. Then ulcerative colitis we'll talk about later. At CDD we've done over 16,000, and that's my little clinic out there. So I came back from Mayo, 3 years over there, and we started off with one nurse, and somehow she multiplied to 62. And then Helicobacter came on the scene. And so you get involved with the latest. We tried to cure ulcers by using an antibiotic, which didn't work. I was just telling Jake and Dr. Martin over here that we did cultures, and sure enough, you can kill Helicobacter with amoxicillin. We got 18% kill rate in patients. And yet it killed it in vitro so well. I couldn't figure out, well, if it's sensitive, like a urine infection, why doesn't it kill the Helicobacter? But this surgeon came along, Michael Munton, he said, why don't you just add another antibiotic? So we did, and it ended up being bismuth, tetracycline, and flagyl. And that was the most successful triple therapy, which was acknowledged at the World Congress in Sydney in 1990, and we then started using treatment. And there was a retrospective study done recently of what impact that had, and that will be published soon, but it says that it prevented the death of 18,655 people and saved the federal government $10.033 billion. And I'm ashamed of the simplicity of it. When you think back, it's very simplistic, isn't it? Look back, I mean, it's so easy, isn't it? And so this was sort of a start. It took 26 years for gastroenterologists, seemingly educated people, right, to use antibiotics for ulcer disease. Because you know ulcers are caused by stress and acid. No acid, no ulcer. You know that. We've got this with Crohn's now. Seemingly educated people. Okay, I'll stop here. So, but it is that simple, you know. Wherever there's inflammation, look for infection. So we decided that after the triple therapy experience, where we learned that it's not a single antibiotic that matters, but it's got to get into the cells, because it's intracellular. You can see it inside the gastric cells. It's in the it's in the biofilm, and you've got to really look after another thing. So I did my PhD on Helicobacter and why it's resistant. And when we did cultures from all over the stomach, we got up to 10 different strains in the same stomach. No wonder the bugs didn't die with a single antibiotic. Even now, you can't get rid of it. We've recently been using, instead of a PPI, I was just talking to Dr. we use vonoprazan. If you ever want any program, actual protocol on it, I'll send it to you if you just contact me. And that brings the pH to such a level that the antibiotics work so much better. We just submitted an abstract to DDW, it was December 1. We got a 98% versus Nexium HP7 of 76%, except that most of ours were double or triple treated, so the vonoprazan really had a hard job. So it's the little gastritis, which is like a colitis, but in a different organ. It teaches us quite a lot of what we work in, because we see this chronic inflammation and we think, what the hell are we going to do here? And we treat with Tagamet the symptoms of the colon by using anti-inflammatories. All right. So extensive trial and research we've done in microbiome. We got 4 full-time research people. We started the focus trial. Sudarshan did my locum today because I had to come here. And we have been for the last 4 years using lyophilized capsules of FMT, which my daughter called crapsules, as you can see. So just lessons in C. difficile. FMT is installation of minimally manipulated microbe communities from a stool of a healthy donor to a patient who needs a treatment. You can use it either as full spectrum material or consortia of organisms. And I think at the end of the day, you'll see when we talk about Eisenman, we're going to be using consortia because you can do GMP on that, okay? Good manufacturing practice. Now, in terms of the TGA legislation, because we're currently involved with, some of you would have been at the TGA meeting in Melbourne. TGA want to have some sort of control, but the Act of '89 excludes it as a drug. For a biologic, the colonocytes have to be doing the activity. You guys know Michael Camm very well. He says to me, we've got to get it through as an organ, like bone marrow. Why? Because the TGA have no control over organs. None at all. Self-stated in the Act. You can't do GMP on kidneys, can you? All right, there's some fun in this. So I'm not sure what will happen, but they give you lectures on good manufacturing practice for half an hour, then they ask you a comment, And each of the people who are doing FMTs got up and said, if you bring in GMP, we're going to close our unit. You can't make GMP stool. Very difficult. So I thought I'd show you the Eisman paper, 58. Despite adequate fluid therapy, this 46-year-old guy who had surgery and had pneumonia afterwards and antibiotics, despite IV fluids, cortisone, albumin, his diarrhea continued unabated. He appeared to be in terminal stages of his critical illness. This is when Eisenman spoke with the wife and said, we're going to give an FMT. Fecal enema was administered using donor feces from a normal subject who had received no antibiotics. This is 57, mind you. This is last century. It's almost as old as I am. Can't believe this. So on the following day, there was marked improvement in his general condition. His bloody diarrhea ceased. They gave him a second enema, and the patient improved rapidly and was discharged from the hospital 10 days later. Whereas for 4 weeks, he was in intensive care with the best standard of care therapy, and poo fixed him. How powerful is that? So this is this whole explosion of knowledge, but look what Eisenman then says. Then in the future, what does he say? We're going to get pure cultures and put them into enteric-coated capsules. I mean, that is seeing over the horizon, isn't it? Very impressive. So mechanism of action, we don't really know for sure, but it could well be that patients with relapsing CDI, we know they have a virtually non-detectable 2 major groups, Bacteroides and Firmicutes. And FMT implants, Bacteroides and Firmicutes, which elaborate substances that you can actually measure in wells that spread and suppress C. difficile if you have it like a lawn culture on a culture plate. So there are substances made by stool bacteria that are antibiotic-like. So this is Martin Green, who did his PhD with us. He showed us 60 to 80% donor-derived flora durably colonized the GI tract. They were early work, but nevertheless, the Bacteroides and Firmicutes returned to normal with a bit of a commentary. Sometimes if you just use spores and nothing else and get rid of the C. diff, and there are no firmicutes and no Bacteroides, they too come back. Remember we were discussing where do they come from? Where do they come from? They're in there all the time, but they're hiding somewhere. So this is, it's Alex Carruth's from Minneapolis. It shows you the bacterial composition before and afterwards, and the orange is the color of the Bacteroides that actually implanted from the donor. And it was a little bit less, but it continues, and by about 6 weeks, the flora starts looking like that of the donor stool. Now, I'm not going to spend a lot of time on this because the other clinical stuff I think is more interesting, but the donors, we're very particular. We're kind of less than 1% accepting of donors. Quite a few will come along just to get the money for the stool, because it's an income and I'm not sure what they spend it on, drugs, so we won't accept anyone who has tattoos, would you believe? Am I discriminating too much? Maybe. Been in jail, lived in England during the mad cow disease. So it's a much longer and extensive questionnaire, and we have 3 full-time nurses looking for good stool, mainly because we do a lot of home infusions for colitis and Crohn's patients afterwards, which I'll explain. But they're basic things. You don't want to have someone with IBS or IBD. And we screen for more than that, but we do now more what Open Biome does. So this is the model that we have with Open Biome, which it requires the use of frozen stool. So you can freeze it, test it, retest the donor, nothing there. You've got much more comfort that the frozen stool you've got stored can be sent out, because it doesn't have an infection, and the person who gave it doesn't have an infection. So they're into about just under 1,000 hospitals around America, and they have this little process, because when we visited last in Cambridge, you wear this little poo hat, and if there's a good worker, they have 155 employees, large numbers of -80 freezers, and if someone excelled, they get to pin the next map hospital location, and they all get a clap. So what happens when you see a patient and you have to discuss with them the possibility of doing a fecal transplant? Well, we go through the fact that you can catch an infection, that you might have an allergic reaction. We've not seen one yet, but we stop them eating nuts. Possible that we are predisposing the recipient to diseases the donor will develop in the future. That is a possibility. Although I always say that, remember, the donor has trialled this stool for 30 years, let's say. Who trials blood pressure tablets for 30 years, you know? Nevertheless, animal models suggest that the microbiome may play a role in pathogenesis of other conditions, and that is how you discover what conditions work. You do a Clostridium difficile patient, and their alopecia totalis disappears, or almost disappears. The 2 cases done in the States. So we're just about to do a trial on 10. So you learn from unexpected findings. Like you had a patient with MS, right? So how do you deliver it? How do you give it? We've given it many different ways. The dangerous way is nasogastric. You don't want to do as a nasogastric tube. If you're going to do it, do a nasojejunal, long way down, small volumes, 3, 4, 5 times in a day. In Nanjing, Fei Ming Zhang does this way, and he does oodles of patients. I think he's done about 130 colitis patients. He seems to reverse Crohn's, if we believe what happens there. And the Crohn's patients, even if they might have a phlegmon, which is published, he's got about 16 cases. It's very hard for me to believe that a phlegmon will go away when you put in poo into the distal jejunum, right? But that's what's published. So we know that retention enemas and not lower endoscopy, but colonoscopy to the cecum with infusion into the cecum, which is what we do, actually probably is the safest and easiest, and I like to know what I'm putting it into. You want to know if there's any polyps. We remove the polyps at the time quite safely. We've come across 2 cancers in patients who were colonoscoped recently, little ones in a sigmoid, and of course the future is going to be encapsulated, I think, although it doesn't work as well as liquid, because you lose some families of bugs. So the cumulative evidence is that, although the figures are not 100%, they're close to 90. And the interesting thing is that we don't do a single infusion. We do first transcolonoscopically, gives you about 90% cure. Second one is an enema next day, gives you about 98%. The more you do, the higher the cure rate, which is what is being done in severe CDI. So probably the better results are from bottom up. The preparation, we do just a bowel prep, and there's a good reason for that. We continue the vancomycin until the day or 2 days before. We will homogenize 50 to 200 grams of stool in saline, and we do an anaerobic collection now, so that we use, I don't know, what do you do here? Do you do anaerobic collection with oxyrase? Oxyrase is oxygen erase, removes oxygen, and we've got an anaerobic chamber, and it's all under nitrogen. I'm trying to maintain Faecalibacterium prausnitzii alive as long as we can, but we don't have an ability to test for it yet, to see that it disappears or doesn't disappear. But theoretically, it would make sense to keep the stool in its natural anaerobic environment. So you collect it within 6 hours of the procedure, you keep it in hermetically sealed special containers, and we don't freeze it, we then homogenize it and use it fresh in through the colonoscope, and we might do, on Monday and Tuesday, we might do 6, say, infusions. It's blended to liquid, the stool passed through a strainer, drawn up into 50 cc syringes. We put it in through the scopes. I mentioned polyps can be removed. We do the full colonoscopy to TI, and we put it in the TI and the cecum, and we use CO2, and this is all the dirty work here. Doesn't look nice, but that's all gets done in a special laboratory. The person who does that has been naughty for the last week, so they get to do it now. And that's just infusing it through a colonoscope. That's Larry Brandt over in Montefiore Hospital. That's his pictures. So capsules versus lyophilized. So we do lyophilization. We've got this huge Noah's Ark size lyophilizer. It's big. It's got, you know, we can do 1,500 caps in one go, sort of thing. And of course, there are advantages because it avoids all the anesthesia. Convenient. No bowel prep. We now use 6 a day for 2 days to eradicate most C. difficile using oral capsules. And we're about to do a trial to actually compare 2 different doses, so we might contact you to involve you if we can and try and do it Australia-wide. The formulation, there's been a number of formulations. We use the one from Open Biome currently, or they actually use ours, and we're starting off with fairly low doses. Liverpool Hospital often calls us, so we take over there, but we always call the TGA, because the TGA said to me, you can do what you like with your patients, but you cannot supply. So we call up, we've been asked to treat a very ill patient at Liverpool Intensive Care, are we allowed to supply? They say, go ahead, I'll send you a confirmatory email, right? So I stick to that rule. It's not a written rule, but it was an oral. So we get the permission, and we've noticed as we increase the dose or treat more frequently, we can get rid of most C. difficiles with capsules, but not colitis, for example. So this is the severe, complicated colitis I mentioned. About 8% are severe. The death rate with standard care, colectomy, has a high mortality, and that's your pseudomembrane. So this is from Monica Fisher. She had 57 of these cases, 19 severe, 38 severe and complicated. She's got 91% cure rate. Several died, 3 died, but Camerotta, you probably know his publications, he just does daily infusions. He doesn't wait till it recurs, but one after the other for 5 days, and he's had no deaths. So the message to us that we've learned from our experience, start the FMT early and treat daily. So we do it for 5 days for severe CDI. And you can tell. The first day, they still have incontinence. Wear a big pad. Second day, the incontinence takes longer to happen. Then after that, they hold the stool. By day 5, they can go shopping. You know, it's just so rapid that the muscle starts responding to whatever makes it weak. So primary sclerosing cholangitis, there was a trial done, And this is the structure of it, but I'll just fly through this. And so some of the findings were that in some patients, you actually get improvement in your sclerosing cholangitis as measured by your enzymes. Now, alk-phos isn't that dramatic in everybody, but if you pre-treat them with vancomycin and metronidazole, which in itself reverses sclerosing cholangitis, there's a couple of publications and a review. So we pre-treat, and here's a patient, as you can see, the liver function test before and after, but he also had 100 fecal transplants. And he's now, years later, has no colitis, no sclerosing cholangitis. So it is a reversible condition. And always remember, you just need one Martian to prove there is life on Mars, right? You just need one sclerosing cholangitis with beading on your MRI, which reverses. Beading takes about 2 years to go away, but it's reversible. We're dealing with reversible conditions caused by some sort of infective agent that sits in there and sends you molecules into the liver through the portal vein. Irritable bowel syndrome, not very well documentable at this stage. Yes, some improvement, but I think we've got a long way to go before we know how to better deliver the stool, how to better prepare the bowel. I mentioned autism spectrum disorder because we're involved with the group, and we treated here 18 children with ASD, and they have mostly got bowel symptoms, abdominal pain, and these children can't complain. But they were able to sleep through the night, and their suffering score in the guts got better, and with time, in the last 3 weeks of the 8-week trial in 18 children, their cognitive function starts improving. So we now have a large double-blind control trial set up that will be starting probably in February in Arizona, where they have good access to autistic children. Now, what's the mechanism? What it is thought. At the age of 2, 3, children get recurrent ear infections. We give them antibiotics. They crawl around the floor and eat cockroaches, whatever, and they acquire Clostridia and Disulfur vibria, which have been well documented by Sid Feingold, Los Angeles, and they produce neurotoxins that enter the bloodstream, attach themselves to Broca's area, and you become averbal or reduce your words. Parietal area and occipital, you get recurrent movements, OCD type movements, and you lose eye contact with mummy. If you put them on vancomycin, say 3 to 4 weeks, the behaviour changes dramatically. And yet vancomycin is not absorbed. Well, it must be reducing something that circulates. Okay? So I think we are in the right space, but it'll take some years before we get answers as to how to reverse this averbal situation. We've got several children now that take capsules that have been disassembled and put into yogurt, and we can get word numbers increasing. And mothers are so excited when they come write us letters or review, because you can measure the words very accurately. So there's something in there, but we've got to now improve upon it and do a blinded trial, which is going to be done in Arizona. So we come to the important area. Microbiota altering treatment for IBD is not new, okay? You've known diversion of fecal stream in Crohn's and severe ulcerative colitis has been used. Antibiotics are sometimes beneficial in IBD and pouchitis especially. Various probiotics have been used and they work like antibiotics, they produce substances. Fecal microbiota transplantation in IBD with CDI has taught us a lot. That's what got our interest. But we reported at UEGW 28 cases of ulcerative colitis with CDI, but only in 2 of them did the ulcerative colitis become dramatically better. I'll tell you one of the cases, because he came to me looking like he had been to a concentration camp. I mean, he was so thin. It was just skin and bones. Colonoscoped him, he's got the worst looking Crohn's disease, right? And he's got C. difficile. Well, great, we've got something to reverse. Gave him 2 fecal implants and then asked him to come back in 4 weeks, because I treat patients with antimicrobacterial therapy. Well, he didn't come back. And I forgot about it, called him at 4 months. And I said, we're supposed to start your antibiotics. And I'm telling this story in Berlin where the UEGW meeting was. And he says, Doc, I put on 40 kilograms, I've done the bridge climb. He couldn't walk before. He was skin and bones. He put on 40 kilograms. So I said, well, come over sometimes and said, look, 7 years now, this guy's Crohn's has disappeared. No antimicrobacterial therapy, FMT only. Histologically normal, but he rang because he went fishing and got diarrhea once. So we brought him over, still normal. So he got something else. Now, I have to tell you his name. His name's Mr. Winner. And this is serious. You have to have a name like Winner for this to happen. All right, so when we first did FMT in 98, Josie, she was the first patient. She was an ulcerative colitis. She has remained normal without ulcerative colitis for the next 30 years. That year, Bennett and Brinkman published in 89 a self-FMT. He is working as a family physician in California. He also has no colitis. Now, the strong message here is that it's a reversible condition. How do we fix it better? Because currently, we're used to treating symptoms. We use Tagamet for duodenal ulcer sort of people. We should be using something that reverses the infection. But we don't think about the infection because it's just not what our colleagues say, is it? And that's what we follow. Unfortunate thing, we follow what our colleagues say. I listened to some Japanese people, Okutsa, he felt that it was caused by Fusobacterium varium. I was at Mayo when he came to give the talk. We didn't believe him. Well, it's idiopathic, you know. We use anti-inflammatory agents. And then we realized that if you take an appendix out before the age of 20, the likelihood of getting ulcerative colitis, and ask every new patient you see, is extremely low, publication of the publication. Why is it so? Well, now we know, because fusos live in the appendix. Appendicitis, mostly without a fecalith, is caused by Fusobacterium. If you remove that appendix, you won't get colitis. We've got to explain that. If you can't explain that, you can't keep working. You've got to explain it. So the explanation was, Okutsa already gave us an answer. He cultured Fusobacterium varium. He gave enemas of the stuff into mice, and they all developed colitis. Then he did a blinded study. He used ATM, I can't forget that, you know, the ATM machine, amoxyl tetracyclometronidazole. Got a marked difference. Did we believe him? No. Do you know his name? No. Do you? I didn't. Had to look it all up. Once we started doing the study with Sudarshan, and we found that Fusobacteria, when the patients get worse afterwards, are the first ones that come back. Okay? So that was Jeremiah Faith. He did our stool tests and, over in Mount Sinai. So there is some sort of a bug there. We're putting our money on Fusobacteria. There's lots of them, but it's just like all the other colitis we see. We see colitis with Eromonas. We see it with Salmonella, Shigella, Campylobacter, Clostridium. If you put your colonoscope in there at the acute time of the infection, inflammation, you'll see colitis. Then a bug goes, colitis goes. So I think we're dealing with a chronic infection that sits there somewhere in the unstirred layer, and we've got used to companies coming telling us that you should use the next MAB, or maybe the next one after that. There's no companies here, are there? But they don't sit here and tell you how to think about trying to solve and cure the problem like we did with Helicobacter, right? And that wasn't believed until the FDA approved it. No one believes from double-blind control trials. I came to that conclusion a long time ago. So there were 4 trials done, as you know. Costello in Adelaide, Sudarshan, Paul Miadi, they were the ones that were powered enough to get a p-value. Rossen didn't get a p-value, but nevertheless, overall, it points in the direction that we can reduce inflammation with a recurrent FMT. And that is from our paper in the Lancet. And you can see from inflamed to uninflamed. And there's a little finding over here. You can see this looks like peanut butter spread. And what do you see over there? It's called Richard the Turd, right? It's a round stool. When you have no more inflammation, the stool will not stick to the wall. We published an abstract on that. No one was interested, of course, because they don't see it. But once you start doing this a bit, you start realizing, and we colonoscope patients without a bowel prep afterwards, after the FMTs that we do, because that's the therapy. We want to leave it in there and not disturb it. And you drive in and you go around these nice little round balls of stool. No inflammation. Take a biopsy. Calprotectin's less than 16. I don't go for the 50 business, you know. It's got to be extremely low. And so we are now starting to see ulcerative colitis patients where you treat against Fusobacteria, we can send you the protocol, until they're histologically normal, then do recurrent FMTs. We get them a kit, they do it at home every Sunday. They get a donor, very hard to get donors at home. And about 1 in 2 lose their colitis long term. Up to 16 years off all therapy, no more colitis. It's a reversible condition. It's how to make it simpler. Okay? So in these 4 RCTs, the thing I want to point out here is that we probably do just as well as the MABs in terms of treatment. Except what I haven't told you, but it's important to understand, that all these trials, although statistically significant, are clinically useless. I mean, who are you going to give FMT every day for the rest of their life? Our trial had 5 out of 8 days of FMT. It's there to prove the point that that's the area to work in. How can we make it better by having fewer fecal implants? Maybe we can go and use capsules better, prepare the mucosa better, all those things that we had a bit of chat about here. But we know it's curable, it's just how to make it better. One of you guys must cure it, it's your job. So this is the appearance of a few patients I showed you. This mucosa 3 is an after treatment of patient off all medications, marked inflammation rectum, which is, as you know, sometimes one of the more difficult things to treat, is proctitis. I'll run through this. This is a lady who gave me, she gave me trouble. She came from Guangzhou. She wanted to know, she'd bring in photocopies from the internet. Oh, can you get me this? Or can you get me that? Can you get me this? And is there anything else I could do? I told her, you can do fecal transplantation. Well, how do I do that? Well, get your husband to be the donor. So she did 69 at home. There she is. And then I went away and someone else colonoscoped her when she came back because she thought she had cancer or something. It was our surgeon, Matt Rickard, and he did not realise the significance of it because he didn't look at the previous colonoscopy. Then she came back 2 years later, and she's been years now off all therapy, and she believed me, and her husband was the donor. So when I last saw her, oh, can we get some of your husband's stool because it looks like it can cure colitis? Oh, no, you cannot have his stool, you know. I couldn't talk her into us doing some metagenomics on it. But I don't know why, you know. It could help children. No way, man. I'm not giving you his poo. He's my husband, you know. So does it work in Crohn's? And the message is colitis is much easier to reverse, as you can see. I won't go through each one of these, but no one has actually done a large study like we did like with ulcerative colitis. But we have cases here and there where after antibiotics we can continue with FMT and patients lose their Crohn's, right? So we now use, this is what I'm coming to, use anti-mycobacterium antibiotic therapy, and then once we get histologically normal bowel, which we can achieve in most patients now, we then follow with recurrent FMT. So this was presented at UEGW, October 30, Phase 3 randomized double-blind placebo-controlled multi-center parallel group study to assess efficacy, safety, etc., etc. So they had add-on therapy. It was called MAP-US, and most of you know David Graham. He's 1 year older than I am, I think. He's an old man. He's from Baylor College. He started the journal called Helicobacter. He's still the editor of it. And so he was our PI, principal investigator. So this was called RHB, after Red Hill Bio 104 MAP study. It's a global randomized trial. It's add-on to current standard of care. It's a fixed dose of clarithromycin, rifabutin, clofazimine in small capsules, which will be increased, BD, until they got to the doses that we used. So it's an escalating dose. We escalate the dose because we wanted to prevent uveitis from happening. If you straight away start with a high dose, you can get uveitis. So they ended up with 331 subjects, 100 sites, and they were stratified for various other drugs. And just to show you the bottom line, remission at 26 weeks, response, they were all highly significant. And there was another one that they did 16 weeks, so we're not sure when they should be looked at. And so we've got primary and secondary endpoints with lots of other slides that I could have put in here, but it's boring. But it looks like we are now hitting a bacterium, which we think is mycobacterium because we can detect it by sending blood across the slot to New Zealand, to John Aiken, who then cultures macrophages, stains it, and tells us who's got MAP. I can give you that data. So this was the poster we put up of prolonged endoscopic remission, mucosal healing in Crohn's patients off all treatment for 3 to 23 years. We now have 16 of them. One of them is one of the gastroenterologists at 5 Doc. And it looks like if we put them on the antibiotics and they get healed histologically, we then replace the flora because we've damaged the microbiota with antibiotics for such a long time. And for some reason, like that Mr. Winner, except that we have normal bacteria, normal mucosa, we look like we're able to reverse the condition in about 1 in 2 when they finish the 24 weeks of enemas. So I think that opens the door to us trying to make it a simplified approach. We're currently working on this, and then we'll probably do a large trial to be able to see what percentage of patients we can get Crohn's to disappear in like we did with Helicobacter. So these are the guys who are involved in the work, and there's Sudarshan here, who got stuck in Sydney doing my procedures today, and the staff, they're good kids, and thank you very much.
I'll take some questions from the floor. I'm sure there's a few questions out there. Does anyone start it off?
I can start it off. So, Tom, in their trials with IBD, all of the fecal transplants were from pooled donors, and that was because of the super donor effect, I think, that was seen in some of the other trials, where some donors were better than others. And so, would you advocate pooled donors, and should we be using...
Just repeat the question because it's being recorded. I was warned.
Okay, I'll repeat the question. So in your IBD trial, in the FOCUS trial, it was pooled donors. So they were pooling, on average, I think 6 donors together for each transplantation because of this super donor effect, or poor donors. And we're doing a lot of CDI work where we're using single donors, often a close relative who has the same diet and lives in the same household as the person who's sick. So what should we really be doing going forward? Should we be using individual donors, or should we really be having a stool bank so that we can have pooled donors?
I don't have strong feelings about this. We've used single donors. We've mostly been pooling 7. And for the FOCUS trial, they were all pooled, and we gave them FMTs for 5 out of 8 days. I had this belief that if one donor's stool is deficient in one area, the other one will make up for it. I think the more powerful thing is to go for anaerobic production, although I can't get open biome to do it currently. And so I don't really know. But it makes sense because Paul Miadi's trial was failing and failing and failing. He reported it the year before as a failing trial, and Harris got up, made a mind, said, don't stop, keep going. And he got the super donor, and the donor pulled him out of a p-value that was less than 0.05. So I think that's to be shown. There are a few papers now that talk about how to identify the best poo sort of thing, but I think it's a bit early at this stage.
With you obviously have run a number of trials. You obviously got a lot of experience in your clinics treating patients. Do you know your figures for, say, mild to moderate colitis with FMT and with, not in the trial sort of environment?
So we have a systematic approach to patients who are referred to us because the colitis is not responding. So we get the difficult ones, right? And we put them on anti-fusobacterium treatment first, which is rifaximin, tinidazole, and nitazoxanide. And we treat until they, I can send you the protocols, by the way, until their calprotectin is right at the floor and staying there. And then we set a date for their recurrent FMTs. They get taught, they get a kit, they go home and they do infusions. We also use, by the way, which is worth noting and checking if I'm right, Ellen Sherrill did a trial of 10,000 versus 1,000 vitamin D. That's why I use 10,000 units daily of vitamin D. And that in itself put Crohn's patients in remission. And we think, because in culture, mycobacterium is inhibited by vitamin D, macrophages kill it better intracellularly, and I've got all the papers on that. So we use it, and clinically, you should have your patients with a vitamin D level of about 150. Do not be afraid of 200. The current vitamin D levels, I'm talking on vitamin D unfortunately too much, I suspect, the levels are all too low. Because if you go out to the community, about 80% are deficient. So your normal levels are built from deficient patients. So some pathologists now say it's 100 to 250. I aim for 150. And that makes such a big difference to bring them into remission. Then we maintain them on vitamin D afterwards and just do FMTs. And about 1 in 2 end up having prolonged remission. I don't want to call it a cure until it's 3 years off all therapy. How many years would you take before you called it a cure? You know, it's very hard to know because it's not cancer. We do know that if you stop all therapy on colitis patients now, generally speaking, the relapse occurs within 12 months. So I made it 3 years.
Can you hear me? Yeah. I've got 2 questions. The first is to do with, have people looked at what the biome is after you've done your collection, and then if you either freeze it or encapsulate it, have people cultured it and looked at the various populations of bacteria to say, is it actually anywhere near what you started out with when it was fresh? In which case, like, have you killed a certain proportion, and does that give you a clue for what's important? And the second question is, are you concerned with the current ideas that if you change your biome, you potentially change what diseases someone may have or develop in the future? So if you have a donor that's going to develop motor neurone disease or obesity, is your recipient going to develop one of them?
Okay, so the first one is about capsules versus liquid, and I think capsule is inferior. And yes, we have had some studies done. Finch do it for us over in Boston, and we miss some families by simply having them freeze-dried and then unfrozen. So I think those very sensitive ones, we kill them off. We're now thinking of supplementing the missing components, especially Faecalibacterium prausnitzii. That is the sort of number 3 component in our normal stool and is a great inhibitor. Some of the things that you may want to use in your clinically in patients, there are oral supplements of apelpectin and inulin and NAG, N-acetylglucosamine, which is added to cultures for culturing Faecalibacterium prausnitzii. Now, if you give it to a donor, the recipient's bowel symptoms improve dramatically. So I think it grows something, and I'm hoping it's Faecalibacterium prausnitzii. I haven't measured it. We're going to start culturing. We've got a microbiologist starting in February, but I'm just a clinic, you know. I just happen to be a large one. But we're trying to get more science into it. So I think the capsule's got a long way to go. Finch is currently, this is public knowledge, contracted by Takeda to produce fixed sort of combinations as maintenance therapy for ulcerative colitis, because you can't keep doing enemas. So that kind of makes sense. A lot of patients now choose not to have immunosuppression. And we kind of get overwhelmed by patients wanting to have a fecal transplantation, for the most stupid indications, by the way. I just knocked them back. So the second question was, sorry, just...
whether you think that a recipient
might can they develop a long-term disease? Look, I think it's a very fair question. I don't know the answer, but I've been doing it since 1988. So that's like 30 years. So you'd expect some diseases to be forming now. Mentioned before that the donors are often people who are healthy and have been healthy for 30 years, have been keeping that bowel flora inside them. You couldn't test better than that, right? And so it's possible. The likelihood, I think, is very low. I think the condition that you mentioned, I think, is going to be a flora-driven condition. We're just getting an ALS patient coming out from Tasmania saying for an FMT because it's theorized by a neurologist in Washington State that it's caused by an atypical Clostridium because they produce neurotoxic agents like Clostridium tetanus, Welchii, perfringens, difficile. There's about 230 Clostridia. One of them is C. diff. There's 198 of those. The diversity is kind of overwhelms me. You know, we'll never learn that. It's just too complex in there. 100 trillion someone counted, and our body's only 10 trillion cells. We're 10% human. What's the rest? Some of my best friends.
Professor Borody, nice talk, and you touched on some nice, an observation that I think is a nice observation, that the colon has only got a limited number of responses to any sort of insult, whether that be Salmonella, Campylobacter, and so ulcerative colitis. Is there a group of patients with ulcerative colitis that you can detect will respond better to FMT? You know, Jake hinted that there's a super donor, but is there a subgroup of ulcerative colitis who have some serum marker or some biochemical marker that you can say, well, you're going to respond better to FMT? And you alluded it to with...
I think it's a very good question. I'll look out for it more, but I don't have indications that they will. In Crohn's, different story. We've treated what we call virgin Crohn's, ones that haven't been to a gastroenterologist. They've never been treated. Within 6 weeks, they heal their colitis, the Crohn's, right? They're usually much younger, and we're just putting together a publication for a case journal. And so there, I know that those go into remission quicker because when you put into the microbacterial culture in Christchurch, any of those medications, including steroids, the bugs become much more dormant. They don't multiply as well. Interestingly, both infliximab and Humira adalimumab, they both have antimicrobial activity, as published by Bach, Horatio Bach, like Johann Sebastian. If you want those papers, I can send you papers if you want to, by the way, because it's such an interesting area to me that we're just doing a Helicobacter of the colon, in a way, you know. And if we could, it'd be so nice if Australia cracked it, you know. And we've got enough guys here with girls too that have got colitis patients. If we just designed the right thing to get 60–70% of these patients not to have a relapse, it would be just wonderful. But I don't have a marker that says you're more likely to do better. It's more like compliance is the best marker.
And with the anti-MAP therapy, you mentioned you were sending patients serum or samples over to New Zealand to check if you can find microbacterium. The ones who have a positive microbacterium, do they respond better to anti-MAP therapy versus those who you can't detect?
I've not had one that's negative. In the past, we couldn't culture it. We had a couple of grants where we could only detect it in 40%, but it was our detection methods. Whereas the new way of culturing it within its environment, that's inside macrophages, I mean, they just light up the cell, they're inside there. And they like to grow intracellularly, like tuberculosis. They're a different type of tuberculosis. And as you know, TB, like bovine, likes terminal ileum. This thing likes terminal ileum. So it's a TB-like syndrome, but it's an atypical one, you know. And so we've got to get used to the fact that you can't get inflammation without infection these days in the guts. What else is causing it? We know it's not autoimmune, does not fit the criteria for autoimmune disease. You've got to get away from the thinking. It's got to be infection. The trouble is that it's so hard to detect. If we could detect it like we did with Helicobacter, the battle would be over, I'm fairly sure. Because we'd all say, well, the bug's there, well, you just haven't got rid of it. That was David Graham. He was such a tough guy. You know, all these young guys are presenting data, and he'd get up, your data does not confirm what you have concluded. Sit down, you know. That's true. It would be so simple if we had a nice, easy to detect pathogen and then we could show that it's gone and that the disease is gone. I think it's going to take a long time, but the first trial, phase 3, has been done. They'll do another one, it'll come out on the market, and then I'm sure there'll be a lot of improvement. But when you combine infliximab with anti-MAP, the healing rate goes up to about 85%. That's the remission rate. So your CDAI comes down to below 150 very quickly. And that's the other thing I'd like to ask you guys, that you write down, when you first see the patient, fill out a CDAI form, and then just follow it on that, calprotectants, just to be able to look back and then maybe collect up the cases and learn from each one of those. It's so important to do research in clinical practice. I'm taking your time.
Just a very quick question. Does the mucosa have to be damaged for it to work? I'm thinking particularly about the fact that results aren't as good in IBS, and also then for liver disease in terms of translocation of bacteria, why they may not be the same response. Is there something about the mucosal breach and the interaction of the inflammatory response at that interface?
So does the mucosa have to be damaged for therapy to work?
Yes.
Look, I've not looked into it, but there are papers by a man called Alexander Svijinsky, who is in Humboldt University, the other side of the Berlin Wall, still on the east, but no longer east. And he stains for, he uses fish, which is fluorescent in situ hybridization, and he can see the bugs, of different types of bugs, that grow in the mucosal layer. He can show how much damage there is. And interestingly, those bugs are in the first 5 or 6 layers of our human cells as well. You see the goblet cells there, because I look at his papers a bit. And you can see that this mucosa, that the mucus has not blocked the entry to these pathogens. Whether the damage has to be there or not there, I'm sure there's always damage there, but I'm not able to measure it very well. You know, I can't just take a biopsy and ask the histopathologist, the mucosa damaged? And they'll say, oh, you've got high inflammation, lots of white cells, lots of neutrophils and lymphocytes. But beyond that, they can't give you a huge, beautiful colour. Electron microscope doesn't give colours, but something like that, which we do at UTS now, because we're measuring this area, and see if we can fix this area up. What's it look like after treatment, before treatment, which I was telling you we're doing. But it's where the battle is. It's at that level of mucosa where the mucus layer permits entry of the pathogens, you know. And why does this one stay? Why does C. difficile go away? Well, because the mucus layer is only 20 micrometers, but in colitis up to 450. So I think we've got a battle of the mucus, sort of thing. Not of the bulge.
Okay.
Thank you. Thank you.
Thanks very much, Prof. Borody. It's great to have you up here, and it's really inspiring actually to see an experienced gastroenterologist so passionate about his research and clinical work. So thank you again. I just wanted to give a quick plug to our NUSA meeting next year. We've got dates set down for June. We're busy working on the program at the moment, but it's shaping up to be a great meeting again. And Jane, I just wanted to check our first dinner meeting next year. What was our, do we have the date? What was it? 19th of February is our first dinner meeting next year. Now, was there anything else, Rich? Did you have anything else to say? Thanks very much, everyone, for coming. Have a great Christmas, and we'll see you next year. Cheers.